Hey everyone, this is Dr. Patrick O'Malley with the laceration course. All right, this particular video here is going to focus on the interrupted suture. Now, the interrupted suture is what you are likely to be doing most of the time as you start off as a student, as a clinician, wherever it is that you end up working. The first sutures that you are expected to know and master are the interrupted suture. All right, so you must master this technique. All right, so the suture pad that you have has ample room for you to do this dozens of times, if not 100 times or more. All right, so repetition is the key. You need to do this over and over and over again. It's a lot of fun. With doing this course that I've put together, I've even taught my son how to do this. He's 8.5, and he's constantly asking me if he can do some Y-shaped lacerations and horizontal mattress and things like that. So anybody can learn how to do this, but in order to master it, you got to do it over and over again, and repetition is key. All right, so as we've talked about in some of the previous videos, you want to properly grasp your needle, loading and repositioning with your forceps, and you want to enter the skin at 90 degrees, as you can see here in this image. All right, our goal here is to aim for symmetry. You want to enter and exit the skin as close to 90 degrees as you can, and then enter and exit the skin in the same distance from the wound margin in most cases. Now, if you have an oblique shaped wound, an injury that comes in at an angle, you may need to alter that approach, but for right now, for learning purposes, you really do want to keep things symmetric, entering the skin at 90 degrees and entering and exiting the skin at the same distance from the wound margins. All right, so with real tissue, you're going to be using your tissue forceps to manipulate the tissue some to help facilitate this, and we'll talk about this more later. And the symmetry will help with proper skin eversion. That too is something that we're going to talk about shortly. All right, so you want to enter and exit the same distance from the edges of the wound so that when you're done, the path of your thread looks something like this. All right, you're going to exit and enter the dermal layer at the same depth. Now, in clinical practice, the goal is to achieve this slight eversion of the wound. That's what I talked about earlier, so that as it heals, it lays down nice and flat. Now, if you space your sutures too close, too far, or in an uneven pattern, you may get something that looks like this. You can see how different mistakes can lead to abnormal tissue line when the wound is closed. Remember, if you do something like this, you can always remove the sutures and start over. This is what you want to aim for with real tissue. As we discussed in an earlier video, do not try for this degree of tension and eversion with your silicone pad, because you will be much more likely to damage it and tear through it. All right, as a general rule, whenever you are putting interrupted sutures in, you really want to aim for about 4 to 5 millimeters between each suture. Sometimes it's going to be more, sometimes it'll be less. As with all things, it just kind of comes to you with time and practice. All right, so I've talked your ear off here. That's enough about this theory and all that boring stuff. Let's practice a few interrupted sutures. Pick a spot on your suture pad, maybe one of these, kind of long, nice, and straight wounds to start off with. And I'm just going to make sure that this is well within the field of view. Okay, so what we're going to do is we're going to put a couple of interrupted sutures right here. We're going to start at this end and move towards the right. Thinking about this when I was putting this video together, I've really not put much thought into this, but I find it easier to work far to near. For me, it's easier to go left to right. Some people may prefer to go right to left. Again, it is going to depend on the individual laceration, the location of the laceration on the patient's body, and your positioning, where you're going to be. But typically, I kind of like to go from left to right or far to near. All right, so you're going to figure out what is most comfortable, makes the most sense, as you are doing this with patients. All right, so we're going to start right here, and I'm going to do a single suture. And I'm going to talk through and mention some of the things that we've addressed in this video and the others. So I'm using my tissue forceps, holding it with my thumb and my index finger, and I'm going to be doing that to help stabilize the tissue. I'm going to enter the tissue at roughly 90 degrees, and I may help present that tissue to the needle with my forceps. So I'm going to enter, I'm going to rotate my wrist. I'm going to rotate my wrist so that the needle comes out in the proper layer here. Well, okay. And then I'm going to use my tissue forceps on the opposite side, kind of evert the tissue a little bit. I'm going to enter, and then I'm going to exit. All right. And what I'm doing is just kind of rotating my wrist. Now, the things that I want to aim for and look for are symmetry. Did I enter and exit the epidermis at the same level or the same distance from the wound? Now, sometimes whenever you're in this position, if you got a long suture, you can grasp it with your fingers and simply pull it through. We talked about on the previous video with the instrument tie, I usually try to leave about 1 inch of tail hanging out on the proximal side of the wound there. And then I'm going to do my instrument tie, all right? I'm going to put the needle driver down in the middle. I'm going to wrap 2 times. I'm going to grasp the tail, and I'm going to pull across, okay? Now I'm going to do that again. Needle driver down, 1 wrap, grab the tail, and pull across. Needle driver down, 1 wrap, pull across. Opposite directions each time. Needle driver down, wrap, and pull the tail across. Okay, now I'm going to cut my suture right there. Now, where does the knot need to be, the central part of the knot? I think most people would recommend kind of pulling the knots off to one side, kind of leaving it over there instead of the middle. If you're leaving it in the middle over the laceration, I think the reason for that would be that you don't want the blood and scab formation to get caught into that knot and maybe make it more difficult to identify. Who knows? Maybe even make it more likely to unravel. So I typically try to pull the knot off to the same side down the length of the laceration. Okay, so I got to practice what I preach here. So I'm going to grasp my needle with the forceps, and I'm going to then grasp it with the needle driver, and I'm going to place my second suture. Okay, so what I want to do is aim for symmetry. I'm going to try to enter the tissue around the same level as the previous stitch. Going to, as you can see, I've taken the needle, after it's been grasped, I'm kind of taking my thumb and my ring finger out of the eyes and putting them in here. I'm going to see, I can visualize where my needle is coming out of the dermal layer. I'm going to use my tissue forceps to stabilize and present the tissue to me. And then I'm going to rotate my wrist and then let go of the needle driver. And sometimes you may need to even go back a little bit more proximal and kind of help guide the needle through. Okay. Then you can actually use your forceps to push down on the skin so that the needle can come through the skin sometimes. And then I'm going to grab my needle with the needle driver and pull it through. Bring it all the way down to about leaving 1 inch. And then I'm going to do my instrument tie, surgeon's knot, 2 throws, just like that. Needle driver in the middle, 1 throw around, grab the tail, pull across. Same thing, over and over. Needle driver in the middle, wrap around, grab the tail, pull across. Needle driver down, wrap around, pull the tail across, and let's do it one more time. All right, so that is the last time. I'm going to grab my thread and I'm going to All right, so that's number 2. We're flying through this. All right, you can always pause the video. You can rewind it and go through with me as you're doing this over and over again. All right, practicing what I preach. Grabbing the needle with the forceps and reloading. All right, now I'm going to show you a mistake. If I get way too proximal on my needle and I'm holding it all the way down here, if you're going through some dense tissue and you start going through and you're trying to force it, you're going to bend the needle, possibly even break it. All right, and then if you are too distal on your needle and you're all the way down here, all right, whenever you're trying to put the needle in, you're not even gonna be able to get it through the first aspect of the wound, okay? So again, that's why it's important every time to be in the middle or a little bit more proximal right in here. Again, each wound is a little bit different. It's trial and error, it's technique, it's practicing, and you're gonna get it. Stick with it. All right, so we're gonna do one more here. I'm using my tissue forceps to stabilize and hold the tissue, entering at 90 degrees. And I'm going to rotate my wrist. I've already taken my thumb and my ring finger out. Come through over here, stabilize that tissue, and come through and grab it with the needle driver. Pull through. Whoop, that can sometimes happen, huh? So I was a little bit too overzealous. All right, and it's something, things like that happen. Not a problem, you just start over. So I'm gonna take the forceps, go through. All right. Now another thing, if you are using a smaller needle or you've got super dense tissue, guess what? You don't have to go through your tissue on both sides in one pass. I can bring the needle and the thread all the way through, okay? And then I can make another pass right here. So that's another important thing. Every time you're doing an interrupted suture, you don't have to go through both sides of the wound with one turn of the wrist, okay? Sometimes you just need to reposition, you need to get better visualization. Obviously a silicone pad doesn't bleed. Well, guess what? Human tissue does. And sometimes just the visualization aspect of this makes things difficult. So if you've got a wound here that's bleeding, it's oozing, they're on anticoagulants, you've got a little tiny blood vessel that's bleeding, sometimes you need to come out and address that bleeding, whether it's with pressure, whether it's with some lidocaine and epinephrine, something like that. But regardless, you can reposition your needle and come through on a completely separate pass. All right, so I'm going to do my instrument tie, 2 throws, pull through, lay down nice and flat, and then I'm going to do another throw. Remember, opposite directions. Away from me. Now I'm talking about in reference to the tail. So I just pulled it away from me. Now I'm going to pull it to me. Away from me. To me. Away. To. Away. To. All right. I did like 10 throws right there. That's way more than necessary. I was just trying to illustrate the point. All right, so that is 3 interrupted sutures. You can fill up this entire thing with that right there, and you will stand out on your clinical rotations and really, really, really be a step ahead when it's time for you to start doing this on patients. All right, so the next thing that we're gonna talk about is let's kind of look at these right here. For the most part, I would say it's safe to say that these are, pretty symmetric in terms of their distance from the wound margins. This first one here is a little bit wider than this second one, so that spacing might be a little bit off. Again, 4 to 5 millimeters usually between each one. Again, that's just something that just kind of comes with experience and different techniques. You can then pull your suture thread so that the knots are all on the side, and that's kind of just an cosmetic appearance thing as well, just so it doesn't look like you've got this sloppy array of knots all over the place. I usually just try to pull them off to one side. All right, so we're going to talk about suture removal. Now, that's another thing that you should feel very comfortable and confident in doing. If you're putting sutures in, you should be able to take them out. Depending on where you work, sometimes that's done by nurses out in triage and you may never see them, but you should get in the practice of removing sutures whenever you have the opportunity. All right, so a couple, it's not overly complicated. Sometimes blood and some pus, infection, scab, can get in here and make things a little bit difficult. If you do have a really difficult one, there's a lot of scab tissue, just put some wet gauze on it for about 5 or 10 minutes, and that usually helps loosen things up. All right, so what you want to do, we've got this little image right here, and this kind of shows you what you're really trying to do. So you're going to be using your forceps, and you're going to grasp the tail of the suture or even the knot, okay? And then what you want to do is you want to lift up. You don't want to lift away. You don't want to lift across the wound. You really just want to lift up and expose and kind of lift up these side aspects of the suture. Now, a source that I just read recently, it's kind of, why do you have to lift up and where are you supposed to cut? Are you supposed to cut at the top of the thread, at the bottom of the thread? And the theory is that you should pull up a little bit and try to kind of push down on the skin and snip the thread as close to the skin as you can. And kind of made me think, and I realized, okay, well, if I'm cutting down here and then I'm pulling up, that's, if you were to cut way up top towards the knot, all of this has been exposed to bacteria. And then if you cut up here and then you're pulling that through the track of the suture thread, I think in theory is that may introduce infection into the tract of the suture and maybe an increased risk of infection. I don't know if they've ever studied that, but I think that's the theory and the principle. So you want to lift up and you're going to push down a little bit, and I'm going to snip my thread and pull out. Now, it's very important, especially with smaller sutures that are in close proximity, you don't want to cut both sides at the same time. I'm going to do this just to show what happens, okay? Whoopsie, I just cut both sides of thread. So what do you see here? You see a tail of suture material that's barely there, and then this one's a little bit longer. If you do that and the suture thread is not visible, you've basically got a foreign body in the skin now, and that is a potential nidus of infection, and it's not good. So it's very important that you lift the tail or the knot up, and then you want to just cut on one side, all right? And then you pull it through. Okay, so that wraps up this video on the interrupted suture and suture removal. I hope this was informative. You can always go back, watch it again. Thanks for joining, and we will see you next time. Hey everyone, this is Dr. O'Malley with the Laceration Course. If you truly want to master the art of suturing and laceration management, you need my course. What we talk about in these videos here on YouTube really only scratches the surface. This online course has everything that you must know in order to take care of patients with lacerations. You can get the course with or without CME credit. We talk about everything that you need to know to properly manage lacerations, including anatomy, pharmacology, microbiology, advanced suture techniques, and so much more. If you're a student or a resident and really want to stand out on your clinical rotations, you need this course. Bottom line is that we're all here to learn how to be able to provide for better patient care. For more information, go to www.thelacerationcourse.com/yoursci, where you can learn more about a 25% off discount for YourSci Practice Suture Kit customers. Don't forget to subscribe to the Laceration Course on YouTube, Follow us on Facebook, Instagram, and Twitter.